Hello, I'm Anna Kroll. I am a women's health physiotherapist, a myofascial release practitioner and a researcher. Welcome to this short series of training videos. We're going to begin with a review of basic female pelvic floor anatomy. So let's have a look at these drawings. We've first got a nice representation of the vulva. Okay, and then when we peel back that layer, what we have deep to that is this. Okay, this is the first layer of muscles within the pelvic floor. And when we peel back that layer, what we have is this, the levator ani. Okay, see how it attaches at the front of the pelvis and then loops all the way around the back and reattaches right at the front. Okay, it's important to remember when we're looking at the pelvic floor that in standing the pelvis is in this orientation. Okay, so the pubic bone is right down at the bottom and the actual pelvic floor musculature is at the back, so it's here. Okay, now there are two important fascial structures that we want to bear in mind when we think about pelvic floor anatomy. Okay, so if I'm a pelvis, so the first one that we want to think about is the tendinous arch of levator ani, which basically runs along the same path as the levator ani. So that's from the back round to the front. Okay. And the arcus fascial tendinous pelvis, which is like a fascial roof within the pelvis. Okay, and the uterus sits into that. Okay, the pelvic floor is really closely associated to our hips. So a pelvic floor dysfunction and a hip dysfunction will always play into each other. Also, the pelvic floor is really closely related to the adductors, which feed right into the pelvic floor here, the abdomen, which feeds into the pelvic floor here, and the glutes, which feed right into the pelvic floor here. Okay, the pelvic floor is also related to our breathing system. It works in synergy with our diaphragm, okay? So inspiration drives pelvic floor expansion, and expiration drives pelvic floor contraction. Okay, so inspiration, we should see a pelvic floor expansion, expiration, and we should see a pelvic floor contraction, just part of the natural oscillatory movements. The tissue just inside the sit bones, so here, is the area of the pelvic floor which needs to undergo the greatest expansion during childbirth. So this is an area where the tissue is really folded in on itself and has a really good capacity for stretch. We need this area to be flexible, even with normal motion. For example, raising our leg, this area of the pelvic floor needs to open, and then with squatting or sitting, again, that area of the pelvic floor needs to open up. Ligaments within the pelvis. So there's lots of ligaments in the pelvis, for example, the cardinal and the uterosacral ligaments. The important thing to remember when we look at it through a fascial perspective is that these are loose weave ligaments, okay? So rather than being a stiff structural scaffolding, they're more of a loose weave, which allows our organs to move with us while we move. If they were really stuck really securely, we'd have no give in the system for being able to move and stretch. So the pelvic floor is an integrated part of our whole. It's a dynamic structure which has a great capacity for stretch and dynamism. The pelvic floor affects and is affected by our global mobility. Things like a restriction in our diaphragm excursion might be mirrored in our pelvic floor excursion. Yeah, a foot, a knee and hip problem is going to feed right into a pelvic floor problem, and vice versa. A pelvic floor problem can cause a change in the way that we hold our leg, and so a knee and a foot problem. Functions of the pelvic floor. Obviously, the pelvic floor plays a key role in our defecation and urinary function. We need to be able to relax the pelvic floor effectively to get poo out and then close it again at the end. There needs to be enough give in the system to allow for proper bladder filling, yet also have a complete and quick enough contraction to prevent any leakage. This is, of course, a dynamic process which requires good organ motility or natural organ movement. The pelvic floor also forms part of our core stability and our centre of gravity. And of course, childbirth. Parts of the pelvic floor will undergo stretch of 3.5 times their normal length to allow for the passage of a baby. And it really does this a lot through this uncurling and unfurling of the tissue right here. Okay, so just here and here, this tissue really uncurls and unfurls to let the baby out. And as important as the expansion to let the baby out is the recoil that we need for postnatal healing. It's quite amazing that we can give birth, open completely, allow a baby to pass through our pelvic floors, and then minutes or hours later be standing up and walking around. So it's important to remember not just the stretch, but also the recoil of the pelvic floor. Let's have a quick look at this, this drawing of a baby crowning, and really have a look at those folds of the pelvic floor uncurling and unfurling around the baby's head. Hello, welcome to section 2, which is fascia and biotensegrity basics. So, our fascia is our connective tissue. It interpenetrates, covers and connects every part of us and forms a continuous, tensional, three-dimensional web. In the words of Gwynber Tao, the fascia is the very warp and weft of the fabric of our body, not the clothing covering it. The other tissues, the muscles, bones and organs are embedded into it. Our fascia is the everything within which everything else is packed. And it's made of 3 things largely. Collagen, which gives it strength, elastin, which gives it stretch, and ground substance, which is a kind of snotty goo, which can be a little more viscous and a little less viscous, depending on certain conditions. And that's what makes it malleable and changeable. Ligaments and tendons are thickenings of this fascial web rather than being separate structures, but force is transmitted through the whole of our fascial web in a multi-directional, multi-planar way at all times. The fascia can be stiffened through things like static postures, repeated movements, tissue trauma and scarring, and it can be released and softened through, amongst other things, manual therapy including massage and diverse movement. If you want to know more about fascia, this is a really good book, David Lasondak's Fascia, What It Is and Why It Matters. It really brings you through a lot of the fascia basics. Fascia and the tensional web that it forms in our body is key to understanding our global structure and how we support ourselves while also being able to move, which brings me to biotensegrity. Biotensegrity was first proposed by Dr. Stephen Levin in 1981. Prior to that, we understood the body as what's called a continuous compression structure, okay? So what that means is that our legs rested on top of our feet, our pelvis rests on top of our legs, on top of that is our spine, and then our head, okay? And the forces in this kind of structure work in a continuous compression way. This is how human structure has been described since the days of Borelli in 1680. And in this kind of way of understanding human structure, movement comes through lever mechanics. Now, in the 1970s, Dr. Stephen Levin, who's an orthopaedic surgeon, started questioning this classic model. There were a few anomalies that he saw through his work. For example, the lack of evidence within joints of the massive compressive forces which would be at play if we really were designed like this. In standing knee x-rays, he could see that the bones of the leg were held apart from each other, which, if we were really a continuous compression structure, how would that come to pass? So he started looking for answers. He came across Kenneth Snelson's tensegrity sculptures based on a mechanical principle first put forward by Buckminster Fuller. Here is a picture. These structures distribute their weight through the suspension of rods within a continuous tensional web of cables. Based on that model, Stephen Levin proposed a new model for human structure and function, which is that the muscles, bones and organs are all suspended within our continuous tensional web of fascia. His model began to offer up explanations for some big questions. How we can be so dynamic and energy efficient, yet also so stable. How we can move so gracefully, yet also be so resilient. How we can work in any orientation, how we can do a handstand and still function. How we can swim, and how we can jump without exploding under massive compressive forces. Tensegrity structures are self-suspending. They can stretch and shift and recoil back into their original position with ease. They work in any orientation, and they are not at the mercy of gravity in quite the same way as these continuous compression structures. The scientific evidence to back up biotensegrity is now overwhelming, starting with Donald Ingber, the cell biologist, who found that cell structure and function could be mathematically modelled as long as a tensegrity model was applied. So he concluded that cells use tensegrity structures to maintain their shape and function, and found that those patterns can be translated at all levels through the body. Then we've got Graham Scarr, osteopath and structural biologist, who did a lot of work around the geometry and force mechanics of living organisms, and again found tensegrity patterns throughout. And Gwynber Tao, with his groundbreaking work in perioperative endoscopy, so that is the filming of moving fascia in living bodies. He concluded that the structural fascial web is global, multidirectional, and works as one continuous tensegrity system. And then we've got the work of Julian Baker, John Sharkey and others who have developed new fascial preserving dissection techniques which have mapped our global tensegrity structure. Research into biotensegrity continues at pace across various disciplines. For example, within the fields of nanotechnology and DNA mapping, scientists have found that right down to the smallest molecules, nature uses repetition and replication of tensegrity structures. And within space exploration, research there is recognising that understanding biotensegrity principles is key to understanding human structure and function on Earth and in space. So biotensegrity is not a theory, it is a firmly established method of understanding the body. But in gynecology, the integration of biotensegrity concepts is very much a work in progress, and it is so important in our field to be understanding these principles. Looking at things through old mechanics, what we're dealing with is the southernmost part of the body that's holding everything up. But when we see the body through new mechanics, that's not the case. So we really need to evolve the way that we understand pelvic floor structure and function and how that works with the rest of the body. In a continuous compression structure, movement comes through lever mechanics, but in a biotensegrity structure, movement comes through the expansion and reposition of tensegrities. So this is an entirely different way of understanding movement, one which is really focused on stretch and recoil of structures. This way of moving, through the expansion, repositioning and contraction of tensegrities, is light, dynamic and energy efficient. Welcome back, this is section 3. So what do these principles mean for the pelvic floor and pelvic organ prolapse? So primarily, the difference is that when we look at the body as a biotensegrity structure, the idea that the pelvic floor is holding everything up from below really falls away. That's just not how we're actually built. An assumption has been made that the uterus, bladder and rectum can fall or droop into the vaginal canal. But the body really doesn't work like that. If we said her brain has slipped down into her neck or her lungs have fallen into her stomach, that would be ridiculous. But women are still being told every day that their uterus has fallen into their vaginal space. So we really need to update the language that we're using around this. Within the old model, it makes sense to promote pelvic floor muscle bulk to limit the width of the hiatus, thereby holding up the weight of the organs and limiting the pull down on the ligaments above the organs. Okay. But when we look at how the pelvic floor really works, it's such a dynamic and elastic structure, so integrated as part of our whole, that actually maybe what we need instead of muscle bulk is dynamism and an ability to recoil from stretch. A quick word about Delancey's levels, because this is a key part of our research base in pelvic health. So John Delancey's research showed us 3 levels of structure within the female pelvis which act to support the organs. Okay, that is an upper level including the cardinal and uterosacral ligaments, a middle level which includes the levator ani complex and the arcus fascia tendinus pelvis, and a lower level which includes the perineum. These structures are recognised as major players in pelvic organ support. And his work is the origin of the ship in the dock theory, which is that pelvic floor muscle bulk holds up the weight of everything so that the ligaments above the organs are not having to do very much. But when there's a weakness, the organs sink down and the ligaments above the organs become overstrained, and so down everything falls. Okay, that's the ship in the dock theory. Now, I'm with Delancey on where those structures are and what they are, but I disagree with him on how they function in a living and mobile woman. Okay. In 2004, Delancey told us that as long as the levator ani muscles are functioning properly, the urogenital hiatus is held closed, so that the vagina is held closed in healthy way. In 2006, he said that the arrangement of the pelvic floor muscles allows for the constant activity to close the hiatus, which holds up the weight of the organs. So again, a constant activity closing the vaginal entrance. Even as recently as 2016, he said the levator ani muscles hold the pelvic floor closed. Now, I'm afraid I disagree with that. I don't believe that women are working constantly throughout the day to hold their vaginas closed to stop the weight of their organs falling out. I think it's time that we moved forward from here and looked at these structures through a modern anatomical lens. Outside of gynecology, the way that we understand the body's structure has evolved. The principles that have been discovered through recent research apply to the whole body, and that includes the vagina. Our research within pelvic health is a relatively small research base, so we have a responsibility to look outside of our field and take on board findings from outside of gynecology. We can evolve the way that we understand, assess and treat pelvic floor dysfunction by just getting our heads around a different way of understanding how the body supports itself. All the principles which are found in global myofascial research are applicable in pelvic health. For example, Shah and Ballara from Fascia research said muscles are embedded in fascia, so tight fascia will prevent the muscles from contracting with full power. And then Maeve Whelan from pelvic research has told us that by releasing tight pelvic floor tissue, the amplitude of contraction improves. So that's an example of how we can take principles from research outside of gynecology and just apply them within our field. Welcome to video 4, Dysfunction within a biotensegrity system. Graham Starr has told us that injury to tissues in one region of the body will also cause changes to the tensional balance of others some distance away and might jeopardise their functionality as they adjust to a different structural configuration. So what he means is that injury to tissues in one region will cause changes throughout the whole structure. Yeah? So an injury here is going to cause a tensional imbalance and change the whole shape. Biotensegrity itself is a constant. It's a type of geometry, so in itself biotensegrity doesn't fail, but the arrangement of tissues within that biotensegrity geometry can be altered through a tensional imbalance. Too much tension somewhere in the system restricts the normal dynamic equilibrium and pulls everything out of shape. So in the pelvis, that means that excessive fascial tension can tug on the nearby organs as the body moves, pulling these organs into a place where they're less able to function optimally. Which brings me to a new way of understanding pelvic organ prolapse. So, pelvic floor muscle training is not hugely effective for the majority of women with prolapse. 1 in 10 will go on to have surgery. And the outcomes for traditional prolapse surgery are poor. One of the major risk factors associated with prolapse surgery is further prolapse. That's not the case for most types of surgery. But if the surgeons are picking up an organ within the pelvis and stitching it up higher, if that organ is actually being pulled south through tension, then that's never going to last. As soon as that woman moves, that tensional pull is going to win. The surgeons knew that this type of traditional prolapse surgery wasn't working amazingly for the majority of women and giving lasting positive outcomes. So they tried something different. Sadly, they assumed that failure of the surgery must be because the tissue was really weak. So they tried introducing a supportive mesh. And we all know how that story goes. So maybe we've misunderstood the condition completely. If we start to consider the body through biotensegrity glasses, there is another way of looking at and treating this condition. I believe that prolapse is caused by excessive tension within pelvic tissue, pulling the organs out of their natural alignment into a place of reduced comfort and function. It can be treated by finding and releasing that tension to restore the correct arrangement of tissues, thereby restoring their functionality. For example, imagine I'm a rectum, okay? A nice central alignment through the back of the pelvis, and then some tension is introduced into the pelvic tissue down one side. Okay, that is going to pull my structure into that side, which is going to allow a stool to pocket and a bulge along the back wall. That's a rectocele. Okay, or imagine I'm a bladder here, nice and mobile, but in a nice happy place above the pubic bone. Okay, and then again a tension comes round the inside of the pelvic floor, causing a pull until more and more this bladder is pulled out of its happy place into a place of reduced comfort and functionality. So here it is in the vaginal space, causing an anterior bulge and problems with emptying the bladder fully and with post-micturition dribble. Okay, or imagine I'm a cervix. Okay, so the cervix kind of sits like a chimney inside the arcus fascia tendinous pelvis. Okay, here's the arcus fascia tendinous pelvis, and here's the cervix. Okay, so if a tension comes up this side of the pelvis, that's going to tug on that arcus fascia tendinous pelvis until the cervix is drawn down into that side, which is concurrent with that dragging sensation that women with a cervical prolapse experience. Okay, we've made a short animation to show that in a little more detail.
This bowl represents the female pelvis and the pelvic floor muscles. The pelvic floor is a dynamic structure which expands like this to allow for the passage of a baby. Flexibility here is key. Here are the representations of the bladder, rectum and uterus. According to the principles of biotensegrity, these organs are embedded within the continuous tensional web that is our fascia. Some of the important parts of fascia to consider here are the tendinous arch of levator ani and the arcus tendinous fascia pelvis. Look what happens when we add a scar here. It causes a pull through the adjacent tissue. For scars that occur here, this pull will affect the nearby structures, causing the rectum to deform in shape and bulge towards the area of tension. This is a rectocele. Stool pockets here. For scarring that occurs here, the main line of pull will move anteriorly, pulling onto the bladder more and more until it is pulled out of its normal alignment and into a place of discomfort within the vaginal space. This is a cystocele. This gives the feeling of a bulge within the vagina, problems with emptying the bladder, and post-micturition leakage. If scars occur here or cause lines of pull into the lateral parts of the pelvic floor, the arcus tendinous fascia pelvis is pulled on, like guy ropes of a tent, which cause a pulling down of the cervix and uterus into that side. This is a cervical prolapse and is associated with feelings of dragging. Now, let's release the scar that is pulling onto the rectum. See how the pull is reduced and the rectum shape improves. The size of the bulge is reduced and so is the pocketing of stool. Next, let's look at the cystocele. See how releasing this scar reduces the pull onto the bladder, allowing it to return back to centre where it can empty better and sit comfortably above the pubic bone. And now for the cervix and uterus. See how releasing the scar reduces the pull through the guy ropes of the arcus tendinous fascia pelvis. This allows the cervix to head back home to a central and high up location within the vagina and so corrects the uterus position.
So, evidence. Clinically, this model fits with the successes that we've seen through treatments such as visceral release and postural and alignment correction when treating prolapse. It also explains why so many women are experiencing prolapse-related pain. And it goes some way to answer the question as to why some women have a significant prolapse even though they have a strong pelvic floor. I've been measuring the effectiveness of this biotensegrity approach to treating prolapse with the PFDI-20 score. Okay. So this is a validated questionnaire used to measure the severity of bother that a variety of pelvic floor symptoms give women. Okay, a clinically meaningful score for the PFDI-20 is set at 15%. Okay, so a 15% drop in score indicates that we have a clinically meaningful treatment. Okay, looking at a couple of other studies that have used the same validated measure to measure physiotherapy input for prolapse. Okay, we've got Wiggersma et al.'s trial from 2014, which found that pelvic floor muscle training provided a 9.1% score drop. Okay. Then we've got Dew et al.'s study from 2016, which compared advice only to advice and pelvic floor muscle training. And they found that the pelvic floor muscle training added 3% to the PFDI 20 score drop. Okay. So with this biotensegrity approach, across the data sets that are either already published or are in the pipeline for being published, we're looking at around 50% PFDI 20 score drop across a handful of sessions. And a large-scale clinical trial is in process for planning. Welcome to section 5. So what causes this tension? Okay, so a major contributor to this tension is scarring. Okay, so scarring disrupts the fascial web by tightening up the tissue. Okay, so this is a scar and it gathers up and tightens the tissue, causing a pull through the whole three-dimensional web. Okay, this is a scar. Okay, this is a nice piece of tissue, and then when we add the scar, what happens is it all gets gathered up on itself. Okay, here's the gathering, and here's the pull through the three-dimensional web. Okay. Carol Lewitt in 2012 has told us that soft tissues have to move in harmony to stretch and shift with the body's movement, and active scars will restrict that all the way along the chain. Okay, and Guimbertau has told us that normal gliding and sliding of the tissue is reduced where active scars are present. Okay, so how does this relate to the pelvic floor specifically? Well, if we have a scar here, okay, then what we're going to get is a pull through the system in that direction. Okay, so add a scar here, okay, and you're going to see a pull through the back of the hip, up here into the back, and then internally you're going to see that pull onto the local organs, tugging them down towards it. Birth-related lacerations to the pelvic floor occur in 90% of women who've had a vaginal delivery. So this scarring and tugging down through the system could be happening in the majority of our patients. Okay, so we have a responsibility to assess for that and find out how this tugging through their birth scars is affecting them. Okay, so some of the factors that are going to make that more significant are if there was an infection in the wound. Fowry has told us that an infected wound is going to produce more scarring and so a greater build-up of tension. Okay, and thinking about how that scar was formed, factors such as an episiotomy, the evidence has shown us that an episiotomy done at the right time, so when the baby's head is just crowning, can be protective, but an episiotomy done early, while the tissue is all still folded up, a cut at that point can be provocative. But if we think about how folded up that tissue of the pelvic floor is, that if that pelvic floor tissue is still all folded up when that cut is given, then more tissue is going to be affected by that scarring than if that cut happened as the tissue was on full stretch. Okay, we also need to look at how was the healing in the postnatal period. Was there anything that may have affected that woman's ability to rest and heal properly? Also, we need to consider missed tears. These do happen and can lead to a greater patch of scarring within the pelvic floor. And we also need to look at what happened with the actual stitch-up. There can be a variety of factors that will affect that. You know, it's worth asking what was happening during that stitch-up. Was it an easy, quick repair by the midwife on delivery suite? Or did they have to call down the registrar? Were they down there for an hour? Was there a lot of swelling or blood loss? Was there some difficulty that was going to mean that there's going to be a more complex stitch-up? Okay, and For women where the scar crosses the midline, they fare worse generally. Okay, so scarring is not the only way that pelvic floor tension can build up. Okay, you can have a movement or a neurological dysfunction which over time is going to build up tension within the pelvic floor. For example, a fall or an injury to one leg, over time there's going to be limping and hip hitching, and that is going to build up tension through this side of the pelvic floor. Or there could be a neurological problem where one side of the body is having to grip and compensate, and that's going to include the pelvic floor. Okay, there can also be a direct injury to the pelvic floor through a fall down the stairs, fall off a horse, a bump onto the coccyx. Then you've got the sort of the elite athletes, the pounding or the weightlifting that can come with really using the body to its maximum capacity. That's going to cause a build-up within the system. For example, ballet dancers, there's a whole lot of gripping going on often for many hours of the day for the professional dancers, so there's going to be a build-up of tension in there. Okay. And also constipation, so overstraining to get the poo out is going to cause some injury to the pelvic floor tissues. And emotional response. So the pelvic floor is linked in its behaviour to our emotions, okay? As Susan Cole Clinton says, a woman in fear over-recruits her pelvic floor. And we do have some evidence base for this. Van der Velde et al. Did a study in 2001 looking at what the pelvic floor muscle activity was for women exposed to threatening film clips. And what they found did correlate with the idea that there is a subconscious over-recruiting of the pelvic floor muscles when women are in fear. So why might women be in fear? So there's trauma, there's birth trauma and sexual trauma, there's pain and fear of pain. And there's also fear of being weak or being broken or her insides falling out. That is a really terrifying prospect for a lot of women. So in conclusion, these scars matter, and fear could be making it worse. It certainly won't be helping. Hi, welcome to video 6, which is how does excessive tension present and how do we assess for it? So, the key signs of excessive tension are pain, restricted movement, reduced tissue glide, and tissue stiffness. Those are the signs that you'd look for tension anywhere in the body, so we can look for those in the pelvic floor to ascertain for our patients what exactly their underlying issues are and where they might lie. Okay, so you can start by asking about pain. So it's a significant feature for many women who are coming to see women's health physios about prolapse, leakage, fecal control issues. Okay, so anywhere here at the front of the pelvis, here through the back of the pelvis, the deep hip, okay, the vulva, inside the vagina, any of these areas, if there's pain there, it's going to indicate that the pelvic floor might be part of the problem. Okay, so we can ask about things like defecation pain. Is there pain when you poo? Is it a sharp sudden pain, or do you have a residual ache that lasts longer? The same with sexual pain. Is it right there at the entrance at the moment, or is it a deep ache that lasts for days? What about scar pain? Is that all the time? Is it on certain movements, certain days? We can delve really deep into asking about pain to try to build up a picture of the location and the severity of our patient's pain. It's really important to find out if it's one side or both sides, and what makes it worse and what might relieve it. For some women, a repeated isolated pelvic floor contraction is going to give them pain, and that's a really key sign that we've got excessive tension in those tissues. Next up, looking for restricted movement. Okay, so this is our postural assessment. So there are many signs in the body that there's a build-up of tension within part of the pelvic floor. So as I mentioned earlier, you can see that in the foot. If the hip is stuck into an externally rotated position, you're going to see some issues down that limb, okay? And then with walking, you might see things such as a reduced swing phase through that leg, okay? Or you might see that as your patient walks away from you, there's a real pull through one side of the pelvis, okay? Then there's things like single leg stand, and I like to look at single leg stand twice for each side. Okay, so first up, I'm looking at how well the hip dissociates away from the sacrum, okay? So if everything is nice and elastic and mobile through here, then as I raise this leg, the hip is going to move out of the sacrum quite nicely and come back, okay? Whereas if I've got a restriction happening through here on the pelvic floor, then the more severe it is, the more of a kind of crunching over, cheating you're going to see. You're going to see women struggle to dissociate, so using other tricks to get there, okay? So when it's all good, a nice clean dissociation, and when there's a bit of tension there, you're going to see a bit of difficulty with that coming up, okay? And then looking at what's happening with the standing leg, okay? So again, when everything's working really well, you're going to see a really sharp, clean contraction and balance, okay? So as I lift this leg, you're going to see that everything just works nicely there, okay? So looking here, coming up, and everything works nicely, okay? And where there's a bit more of a dysfunction happening, you're going to see a balance challenge here. So raising this leg, you're going to see a bit more of a struggle, okay? So when everything's working well in here, you should see a nice clean balance, okay? Whereas when there's a bit of dysfunction in here, you're going to see a balance compromise. So looking at the single leg stand twice, once looking at the leg that's raising and once looking at the leg they're standing on, can give quite a lot of information. Okay, looking at medial rotation and abduction also gives away a lot of information, okay? So looking at if there's a restricted medial rotation, if that patient can't take their leg easily across, you've got a tension happening through here, okay? If there's a restricted medial rotation, you've got a limitation happening through this part of the pelvic floor. And if you've got a limitation into passive abduction, you've got some tension coming up through the chain here, okay? And then we can look at things like squat, okay? So just looking at how easily this section of the pelvis opens out. You can watch this movement and see if there's any clunky bits, or is it a nice, smooth and even opening of the back of the pelvis on both sides, okay? So using your whole postural assessment to build up a picture of where in the pelvis there's some tension and how severe that is, okay? Okay, next up, looking at reduced tissue glide and tissue stiffness. Okay, so for this part, I'm talking to the women's health physios only, okay? Those that are qualified and insured to do digital palpation. Okay, so when we assess women digitally, we need to be thorough, comparing left and right and palpating into the tissues, as well as assessing for contraction and release, okay? Remember, the healthy state of the pelvic floor is one of dynamism and movement, so we need to find out if our patients have a reasonable amount of elasticity where they need it, okay? The problem with purely assessing contraction and let go is, for the women that are struggling, it doesn't actually tell us why. If a woman has got a tight, tense and stiff levator ani, then she's not going to contract to full range with full power. But that could then be seen as weak. You bob a finger in, you ask for a contraction, that contraction doesn't happen. But how do we know if that's because that tissue is too weak to get there or too tight to get there? Well, we can ascertain that by following up that assessment with a really thorough palpation into all of the tissues, okay? And by aligning our findings with what we've just seen in the postural assessment, okay? So remember that this back section of the pelvic floor here is related to our medial rotation. So if you're seeing a reduced medial rotation on that side and the tissue in that section of the pelvic floor is really stiff, then you have an answer as to whether the problem going on in that part of the pelvic floor is tension or weakness, okay? So it's really important to find out why parts of the pelvic floor aren't contracting well, to test it with a multi-directional, gentle stretch into the whole of the back of the pelvic floor, okay? And we also need to find out, when we're looking at organ position, which side has the organ shifted towards. Is that organ position shift on the same side as the reduced contraction? Is that also the tenser and tighter side? And is that the side where you saw the movement restriction in your postural assessment? Okay. Through thorough palpation as well, you might even find that you're able to replicate some of your patient's symptoms, be it their back pain, their hip pain, or their dragging sensation. And again, in keeping with classic physio assessment, if you've replicated a patient's symptom by touching a part of her muscle, then you know that you're on part of the problem. Welcome to section 7. How do we evolve our practice to incorporate biotensegrity principles? Okay, so first and foremost is assessing and treating the whole woman, not just her pelvic floor. Okay, and we need to use up-to-date anatomy to explain what's going on for her and avoid nociceptive language. So nociceptive language is terminology that might be accidentally making the issue worse. Okay, so things like falling out. In all likelihood, that is going to cause a subconscious over-recruiting of the pelvic floor. So we really need to move away from that terminology and instead be describing, a pull out of alignment rather than a falling out. Okay. We also need to treat tension first, looking for it in our postural and our digital assessments, and then treating it before we move on to any strength work. That's in keeping with Amy Stein's work, lengthen before we strengthen. This can begin as simply as giving women permission to stop doing something which is aggravating their symptoms. For many women, they are experiencing a worsening of their pain or dragging sensations with repeated pelvic floor contractions, but they also believe that if they don't do that, they are letting themselves down. So they're forcing themselves through a painful exercise in the belief that they have to do it, come on May. So for these women, permission to stop doing that and help them find the source of their tension is going to be really helpful. Okay, so because pain or worsening of symptoms with repeated contractions really is a sign that that tissue is too tight and needs down training. So where you suspect there's a tension in the tissues, the first line treatment is learning how to let go of the pelvic floor, which is notoriously tricky. So I've included an exercise in one of the later videos. Okay. Also, we need to optimise alignment up and down the chain to take tension out of the system globally. Okay. And we need to find and treat tension through the pelvis and abdomen, which we will all have different ways of doing depending upon our scope of practice. Okay, so that might include release-based movements such as stretches and mobility exercise, child's pose, pelvic tilts, hip releases, trunk releases, gentle rotations, glute stretches, cat-cow, these sorts of things, okay? Or for the massage and manual therapists, any release of the tissues which feed into the pelvic floor, so the abdomen, the glutes and the adductors, any release into these tissues where you see and can ascertain tension is going to help. Okay, and offloading the pelvic floor through safe and well thought out exercise prescription. We can also advise on self-massage techniques. Again, I'm going to cover more of that in a follow-up video. okay? And other down training practices such as mindfulness or simple reminders to switch off our pelvic floor. One nice trick for women that are in a constant gripping state through the day is to just put stickers on the wall, and when they see that sticker to just ask themselves, am I gripping my pelvic floor? And eventually that habit of being in a constant gripping state starts to unwind, okay? And again, this is for women's health physios only, who are insured to work internally, okay? We can treat manually into the pelvic floor if you have the correct postgrad training, okay? And if you are doing that, the most effective areas to treat are those that undergo the most expansion during childbirth. So right at the entrance, here and here, this is the area that undergoes the most uncurling and unfurling as the baby's head crowns. This is the area that requires maximum flexibility for all those normal movements. Okay, the deeper parts of the vagina will only fully release with manual therapy once the most superficial areas have released. Okay, so concentrate your efforts at the entrance to begin with. Okay, and once you've seen some improvement and you're working into the rehab stage, you need to be cautious of ramping up a system that you've just released and downtrained. There's a growing body of evidence within neurological, fascial and exercise science that functional and integrated exercise is better for building a dynamic, resilient and reflexive power rather than repeated isolated contractions, and that we benefit from a rich diversity of movement rather than static postures. Okay, so for example, well-designed and considered postnatal Pilates and yoga programs, or good old-fashioned walking, hill walking and stair climbing. Crawford 2016 did a nice study looking at 100 patients' pelvic floor muscle recruitment, comparing exercises such as squat, lunge, bridge and cat-cow with classic Kegels, and they found that the more functional exercises gave a better pelvic floor muscle recruitment. Okay, having said that, the knack, if you've heard of that, is slightly different. Okay, so the knack is a conscious closure of the pelvic floor on things like coughing and sneezing. Okay, and that actually mirrors the reflexive movement of the pelvic floor that we're hoping to bring back. So that's good to encourage. So that's, you know, using the breath, which inspiration drives pelvic floor expansion and expiration drives pelvic floor contraction. So on the out breath, pelvic floor contraction as you cough and sneeze. That can be a useful exercise to bring in, which aids the bringing back of the reflexive action of the pelvic floor. As does teaching effort on exhalation. Similarly, that's working with the natural movement of the pelvic floor. Welcome to section 8, how else can we help? Okay, starting with prevention. Okay, so preventing a build-up of tension within the pelvic floor. This might be a proper exercise prescription. We also need to look at preventing obstetric injury. So that's promoting active natural labour and staying off the intervention cascade, as well as perineal massage and promoting postnatal healing, nutrition and rest. Okay, in the early postnatal period, we want to be treating every woman individually, looking at her story and her injuries, what are her pain and discomfort levels like, and what kind of support or challenges might she be experiencing. And then later down the line, we can offer lifestyle tips. You know, there's a lot of mums with young children that might just need some tips about moving those children around. You know, at a certain point, they don't need to be hoiked up onto a hip to wash their hands at the kitchen sink. Actually, you can drag a kitchen chair over and help them stand onto the chair. You know, actually, children can climb into that car seat earlier than perhaps they're always thought they can. So, you know, helping women come up with solutions. what does her school run really look like? Is it a 5-minute walk along the flat with one child on a scooter? Or is it a double buggy up a steep hill for 20 minutes? You know, let's really look inside what she's doing and help offer lifestyle tips. Okay, another one with babies is moving to back carry as soon as possible. So that's just much better for her posture. As soon as the baby's head control is ready, you can offer, you know, advice with the local sling libraries. But as soon as baby is ready, it's going to be better for mum's posture if that baby moves to a back carry. And high heels, okay? So high heels are a no-no, really, where there's pelvic floor dysfunction, because huge amounts of pelvic floor dysfunction are happening just here, and just here. And as soon as we're wearing high heels, just to stay looking forward, we have to really clench up here and here. So anyone with pelvic floor dysfunction really should be avoiding high heels. Okay, next up is constipation. So really there's two kinds of constipation. There is the dried up, stiff stool type, okay? So for women experiencing this kind of constipation, it's advice around fluids, cooked vegetables, seeing a nutritionalist if required, okay? But if the stool is soft but is getting stuck, then actually the problem is more likely to land at our door, because that's more likely to be a pelvic floor dysfunction, okay? So things that we can advise on are defecation position, okay? So proper defecation position is actually the deep squat, but with our Western bathrooms, that's not really possible. So everyone should have nice little stools in their bathroom, feet on the stools, okay? Nice open pelvis, elbows on knees. Okay, and gently exhale, okay? We should be breathing the poo out, not pushing, okay? Other things that are going to help with that are going at the first signal, not putting it off, and giving yourself plenty of time, okay? So again, this might just require some lifestyle tips. You know, if mum's busy with several kids, you know, she might just need a little bit extra advice to remember that her pooing is really important. And if she has to take 3 kids with her to the bathroom in order to spend that time being able to properly evacuate, that's what she needs to do, okay? So she needs to avoid straining and pushing. Where there is an incomplete evacuation of stool happening, where there is a pocketing happening, she can add a little bit of manual pressure. That's going to be better than trying to strain through the pelvis to force that poo out, especially if it's in a wonky rectum, okay? So if the rectum's been pulled out of shape and we've got that stool pocketing, something that she can do as a bit of symptom control is just bob a hand onto her perineum, okay? And that might just help for that stool to evacuate. And if that doesn't work, just getting up, walking around and trying again later. Okay, so the rectum is for transit. The bladder is for storage, okay? So bladder training and learning to hold your bladder for longer and longer is fine, but really with pooing, when you get the first signal, you need to go. Okay, the next thing that's in everyone's scope of practice, regardless of your profession, is empathy and compassion, okay? Feeling heard and validated is going to act to calm the whole system, and we can all do that for women. A word of caution about treating patients after they've had radical pelvic surgery. If the aim of the game is to restore our natural biotensegrity arrangement, once some pelvic surgery has happened, that's not going to be achievable, and the patterns are less predictable. So it's much trickier to get someone into a comfortable biotensegrity arrangement once pelvic surgery has occurred. So get to them before surgery if you can. Okay, and red flags. Okay, so if you're picking up women with any of these issues, that's tingling or numbness over the perineum, unusual discharge, discoloration of the vulva, a burning or stinging on urination, a strange smelling urine, blood in the urine or poo, or constant abdominal pain, she needs to see a doctor.